Hello, this is Dr. Garima Sachdeva, and today we'll be discussing about the NICE guidelines on hypertension in pregnancy, diagnosis and management.
So classification of hypertension, are you aware, like in pregnancy, how do we classify hypertension?
Mild, moderate, severe?
No.
Gestational hypertension.
Gestational hypertension, then chronic hypertension, preeclampsia, eclampsia.
Okay.
Do you know what is the difference between these? How do we differentiate?
Gestational hypertension is diagnosed when BP is above 140/90, above 20 weeks.
Okay.
And chronic hypertension when it persists beyond postpartum period.
Postpartum means how many weeks postpartum?
More than 3 months.
Yeah, more than 12 weeks postpartum.
12 weeks.
And
preeclampsia.
Chronic hypertension, other criteria?
Other criteria.
If she was already having hypertension
before pregnancy.
Yeah, or if it develops before 20 weeks, then again it is a chronic hypertension.
Okay, ma'am. So gestational is only above 20 weeks.
Yes.
Okay.
And preeclampsia?
Preeclampsia when there is other features, proteinuria, pedal edema.
So pedal edema is not. It is associated proteinuria. That is one thing.
Okay.
Proteinuria, how do you classify? How do you diagnose? Either you do collect a 24-hour urine sample.
Yeah, there should be more than 4 gram, I suppose.
300 mg.
300 milligram. Okay.
More than 300 milligram in
24 hours.
Yes. Or if you do a urine dipstick, if it is more than 1+. Okay.
Okay.
Or if you do a protein creatinine ratio, if it is more than equal to 0.3 or 30 milligram per millimole.
Okay.
Or albumin creatinine ratio 8 milligram per millimole. So this is how you classify proteinuria.
Okay.
The other features of preeclampsia, like in case even if proteinuria is not there, but if there is cytopenia with platelet count less than 1 lakh or insufficiency, that is creatinine more than 1.1 or doubling the baseline, or if there is liver involvement, or if there are any cerebral symptoms like headache, visual disturbances, convulsions.
Blurred vision. Okay.
So these are, if any of these features are there, again, it is preeclampsia. So if any of these 5 features are there, it is also a severe preeclampsia.
Okay.
Then eclampsia is any of the features of preeclampsia along with patient throwing fits.
Okay.
And then chronic hypertension, you've already told, BP more than equal to 140/90 before 20 weeks. Or if the patient was already hypertensive and on treatment, or if it persists beyond 12 weeks.
Okay.
So this was a classification. So if a patient comes, like, how do you manage a case of chronic hypertension? Then first of all, you'll review the antihypertensives. So in pregnancies, you do not have to give ACE inhibitors, ARB, thiazides or thiazide-like diuretic. The patient is on ACE or ARB, this is a question, you have to stop them within 2 working days of notification of the pregnancy.
If they are already on ACE inhibitors.
Or ARB, yeah, because they affect the fetal kidney.
Okay.
And affect the liver. So they have to be stopped within two working days of notification of the pregnancy.
Okay.
And change to alternatives. Alternatives, we give labetalol or we give nifedipine or methyl dopa. You have to rule out chronic end organ dysfunction. So what organs can be affected in chronic hypertension?
Kidney.
Okay. So for kidney, you'll see the creatinine, urea. Okay. Then?
So upper limit is 1 or 1.1?
1.1 for creatinine. For pregnancy, we say it is generally because there is this dilutional thing also. So creatinine, we take a lower limit for pregnancy. Usually it is less as compared to the in pregnancy because of hemodilution. There is increase in the blood volume. Creatinine like physiologically goes down. So for diagnosis of abnormal renal function, we take the cutoff as 1.1.
Okay, ma'am.
Then other organs which can be affected.
In
Hypertension, what all will you look for if the patient comes to you? She's a known case of hypertensive and she wants to conceive. So what all tests will you do?
Any cardiac issue?
Yeah, you'll do you'll do an ECG for that. Because it can be like blood sugars can be deranged, like diabetes can be checking your sugars. You'll be checking the lipid profile, and even it causes hypertensive retinopathy, so you'll check the fundus.
Okay.
About that. Then antihypertensives you have to change. First line would be labetalol, nifedipine if labetalol is not suitable.
Okay.
Labetalol is not suitable in patients who have asthma, so you have to take a history of asthma.
So it is contraindicated in asthmatics.
Yeah, because it's a beta blocker, it causes bronchoconstriction. So it is not advisable then. So then you give alternatives. Nifedipine is an alternative. Then methyl-dopa. Both labetalol and nifedipine are.
Labetalol 100 milligram. Nifedipine, what is the dosage, ma'am?
Nifedipine we give 10 milligram. We start with 10 milligram. We can give it till 30 milligram total dose.
Okay.
Then the target in pregnancy, like whether it's chronic hypertension or preeclampsia or gestational hypertension, you have to remember it is the same 135/85. Chronic hypertension, you have to give aspirin 75 to 150 milligram once daily from 12 weeks.
Okay.
And
until delivery.
Until 37 weeks.
Okay.
Like once the patient approaches 37 weeks, you usually stop because it's an antiplatelet. It increases the risk of PPH.
Okay.
So, but till 37 weeks, you can give it safely.
Okay.
Then offer placental growth factor based testing. So this placental growth factor, it is a prediction of preeclampsia. So for gestational hypertension, also you offer the same testing if you have to rule out preeclampsia, like whether the patient is at high risk of developing preeclampsia or not, you get to know with this. Okay, so
placental growth factor.
Yeah, so you do it between 20 to 35 weeks of pregnancy.
To rule out preeclampsia.
Yeah, because chronic hypertension also like patients can develop.
Okay. So in cases of chronic hypertension and
gestational hypertension.
Okay.
Okay, and how
they are known for preeclampsia or not?
Yeah, and for how frequently you will call them during the pregnancy? You have to call them every 2 to 4 weekly. If the hypertension is well controlled. If it is not controlled, then you have to call them more frequently. And time of birth in these cases would be after 37 weeks.
Okay.
This was about chronic hypertension. Then what are the drugs which are not useful for preventing hypertension? So nitric oxide donors, progesterone, diuretics, LMWH. So these are not useful. Even magnesium, folic acid, antioxidants, fish oils, garlic, salt restriction. And salt restriction is also not useful for preventing hypertensive disorders in pregnancy. Okay.
But we are putting them on aspirin.
Yeah, you have to put them on aspirin. Aspirin is protective.
Okay.
Then postpartum management, like after delivery, how do you manage these patients? How frequently you have to monitor the BP? So for the first 2 days, because first 2 days there is highest risk of developing severe preeclampsia and throwing fits. So you have to monitor the blood pressure daily for the first 2 days. And after that, once between day 3 and day 5. And after that, only when if it's clinically indicated. Okay.
Okay.
And if the patient is on methyl dopa, you have to stop methyl dopa within 2 days after birth because it is associated with postpartum depression. So postpartum, you have to stop methyl dopa. Okay.
If on methyl dopa to treat chronic, we are stopping it after birth.
So 2 days, you remember in hypertension, ACE inhibitors, ARBs, if patient is prior to pregnancy, stop within 2 days of notification of pregnancy.
No, like why do we give her methyl dopa?
Methyl dopa for controlling blood pressure. So I told you there are 3 drugs which can be used in pregnancy.
Usually we start with labetalol.
Yeah, so labetalol, if patient is asthmatic, you will not give labetalol.
We can give nifedipine, in which case we give methyl dopa.
If a patient cannot tolerate nifedipine causes hypotension and tachycardia. So in those patients who are not able to, or headache also is very common with nifedipine. If the patient is complaining of side effects, then or the BP is not controlled with one drug, then you have to add second drug.
Okay.
Then you offer a review of antihypertensive.
And why are we stopping it after delivery? Methyl dopa.
Postpartum depression.
Okay.
Then you offer a review of antihypertensive treatment 2 weeks after the birth. You have to review them again. In ACE inhibitors, ARBs, they're safe in the postpartum period, so you can start. And the best drug will be nalopril, which is usually restarted. Okay. Again, you send for a medical review 6 to 8. So first you review at 2 weeks for the antihypertensives, and then again at 6 to 8 weeks.
Okay.
Then coming over to gestation.
So for the 2 weeks, they are not on any pills.
Any pills means?
No, it's given offer a review of
labetalol. The more effective.
They'll be continuing only.
They'll be continuing only, but you can change.
Okay, review after 2 weeks. Okay, ma'am. We are just monitoring them.
Yes.
It can be stopped once they become normal.
Yes.
Okay.
But chronic hypertension, usually they continue it later on because they had hypertension before.
Prior to pregnancy.
So you can switch to the medications they were there on prior to the pregnancy.
Okay.
Then gestational hypertension, it is classified as mild hypertension and severe hypertension. Okay. If the BP, like systolic, is between 140 to 160 and
there's no moderate term. Mild and severe only.
Yeah, mild. Two classification only.
Okay.
So if blood pressure is from systolic 140 to 160 and diastolic 90 to 110, then it is milder hypertension. Severe is if it is more than 160, 110. Okay. Then when will you admit for mild hypertension? You do not routinely admit, but if the blood pressure rises beyond 160, 110, you have to admit them until it falls below it and then manage as for hypertension. Okay. Then what is this thing? When will you start the treatment? If the blood pressure is more than 140/90, then you start for every patient the antihypertensive treatment. Okay. And the target would be 135/85. So this is common for every hypertensive patient in pregnancy. BP more than 140/90, you start antihypertensives, and your target should be to maintain the blood pressure below 135/85.
Okay. And we are admitting them when it is below 160. That means when it is above 150.
Above 160, 110.
Okay, so that is above.
Yeah, severe hypertension you admit.
Admit if BP falls, it's below or above 160.
No.
You have highlighted.
In all cases of severe hypertension, but it falls below 160, 110, then you manage them routinely. Like
Okay. Admission is required only above 160. Okay.
And once the BP is controlled, you can plan for discharge.
Yeah, okay, ma'am. Okay.
Then how frequently do you measure the blood pressure? You will measure it for a mild one once or twice a week. And your target will be 135, 85 or less. And if it is severe, because there is high chance that the patient may throw a fit, so you have to measure it every 15 to 30 minutes until the BP is less than 160, 110. Okay. And once it falls below 160, 110, then you have to like, depending on the period of admission, you have to measure it like at least 3 to 4 times in a day. Okay. Again, you measure it frequently once the patient is admitted. Then basic proteinuria for mild hypertension, you do it once or twice a week. This is to rule out preeclampsia. You do it once or twice a week. And if severe, you do it daily once admitted.
Okay.
And then blood tests, you have to do full blood count, liver function test and RFT.
Okay.
Do it at presentation and then weekly. And this is same as same for severe hypertension. Okay. This you are every 1 week. Okay.
Okay, every weekly.
Yeah. So
until the BP is maintained.
Okay. No, every weekly you have to do anyways. Like if she has hypertension, if she's
pregnancy.
Out her pregnancy, yeah.
Even though her BP is normal.
Even though her BP is normal on medications.
Okay, ma'am.
I told you criteria for preeclampsia. If these symptoms are deteriorating, then like renal function deteriorate or liver function deteriorate, or there is thrombocytopenia.
So even if the BP comes to like even 90 or 100, she has to be tested weekly.
Yes.
Okay.
And then placental growth factor, you have to test once between 20 to 35. This is again to rule out preeclampsia. Okay.
What do we do if it is positive?
Then you have to monitor the patient more frequently. It just tells us whether the patient is at risk of preeclampsia.
Okay.
Then a fetal assessment, offer fetal auscultation. This is same for both. So offer fetal auscultation at every antenatal appointment, ultrasound at diagnosis, and then followed by every 2 to 4 weekly. For this severe hypertension, you do it at diagnosis and every 2 weeks. This is 2 to 4 weeks. This is 2 weeks. Okay.
Fetal heart auscultation every antenatal appointment. Ultrasound assessment every 2 to 4 weeks. Okay.
And CTG only if it is clinically indicated. In mild hypertension, you do it only if it's indicated. In severe, you do it at diagnosis and then followed by that only if it is indicated.
Okay.
Timing of birth, this is again after 37 weeks. Provided the BP is less than 160, 110 and there is no other medical indication.
Okay.
So for chronic hypertension also it was after 37 weeks. Gestational also it is after 37 weeks. Okay. Postpartum management, this is same as chronic hypertension. So first 2 days you are measuring on daily basis. Then one between day 3 and day 5, and after that only if clinically indicated. Okay. And suppose a patient was not on medications during the pregnancy and postpartum her BP rises. Okay. Then what is an indication of starting the antihypertensive then? If the BP is more than 150, 100.
BP is 150. Okay.
It's not 140, 90. It is 150, 100.
So after 140, 90, it's not required. We have to just monitor her.
In the postnatal period.
Yeah, in the postnatal.
You have to start even if it's more than 140, 90. Okay. Then coming over to preeclampsia.
And how about normal labor even after 37 weeks?
Sorry, I didn't get the question.
After 37 weeks, mode of delivery will be?
Will be vaginal delivery and cesarean only for obstetric indication.
Okay, ma'am.
Then management of preeclampsia. So again, it is mild and severe preeclampsia. Mild if the blood pressure is the same criteria, less than
Okay.
160, 110. If it is more than 160, 110, it is severe hypertension. Okay.
Okay.
Then again, admission to the hospital only if there are any clinical concerns for well-being of the woman or the baby. Then you admit in cases of mild preeclampsia. Severe, you admit like in all cases. And once the BP, this is again the same, falls below 160, 110, you can manage accordingly. Okay.
Okay.
So this is the same in both the cases. Antihypertensives, you give again the same. 140/90, the BP is more than 140/90, you give antihypertensive treatment, and then your target should be
135/85.
yes. So this is again the same. Then blood pressure monitoring. So this is different. For gestational hypertension, I told you how frequently mild hypertension, how frequently were you monitoring the BP?
Twice a week.
Once, twice a week.
Okay.
However,
Here
in
every 48 hours.
every 2 days. And
Okay.
severe, it is same every 15 to 30 minutes until the BP falls below 160, 110, and then once the patient is admitted, every 4 times a day. Okay.
Okay.
For severe, it is the same. For mild, it is different. For mild, it is every once or twice a week. Here, it is every 48 hours. Okay. In dipstick, you need not do dipstick here because you already know it has no relevance now because you already know she's a preeclampsia. You were doing dipstick because you wanted to rule out preeclampsia. So here it is indicated. Okay, blood tests. So
at
blood
least we'll know if it is only one place or it's going beyond that. Not required.
not required. It doesn't make any changes in the treatment.
Okay. Okay. Anyways, she is on treatment.
And blood tests. How frequently were you doing the blood test in cases of gestational hypertension?
Blood test. We do every week.
Yeah. So for
Every week.
and here you were doing weekly.
Okay.
At presentation and weekly. For
Okay.
my preeclampsia, you are doing it twice a week.
Okay.
For
Okay.
preeclampsia, you are doing it 3 times. So 1, 2, 3, you remember. Gestational hypertension, whether mild or severe, once a week. Mild preeclampsia, twice a week. Severe preeclampsia, 3 times a week.
Okay.
Okay. Then this is again same mild for mild and severe auscultation at every antenatal appointment. Ultrasound here every 2 weekly at diagnosis and every 2 weeks. CTG at diagnosis and then only if it's clinically indicated. Okay, so it's same. Then timing, here you deliver these patients early, especially if it is severe preeclampsia, depending on the severity. If the patient is unable to control the blood pressure, despite using three or more classes of antihypertensive in appropriate doses, maternal pulse oximetry is less than 90%, saturation falls below 90%, progressive deterioration in liver function, renal function, or hemolysis or platelet count, ongoing neurological features such as severe intractable headache, repeated visual scotomas, or eclampsia, placental abruption, or there are Doppler changes, REDF or ADF on the Doppler. Okay.
And so, like, we can give a combination of more than 3 classes also. Antihypertensive.
Not getting control, then.
Okay. What else do we go, ma'am? Go for labetalol, nifedipine, methyldopa. In addition to all these, what else do we add?
Amlodipine, but it is associated with IUGR, so usually we avoid. But if the BP is not getting under control, then we don't have any choice.
Okay.
Or if it's severe, then you give injectables like nitroprusside or hydrazine or IV loop.
In complicated cases.
Yes.
Okay.
Okay. Then
if delivery is before 37 weeks, what is the upper limit in that? It should be above.
If any features of severe preeclampsia, if any features of severe preeclampsia, you or if there is any fetal, like fetus is affected, there decreased blood flow, absent end diastolic.
We will terminate immediately.
After 34 weeks usually.
Okay.
Depends. If it's ADF, then 32 weeks. REDF, then around 30 weeks. So it depends basically.
Okay.
You can deliver before 37.
But we are not going to continue beyond 37.
Beyond 37 for preeclampsia, you do not continue.
Okay, okay, ma'am.
Then postnatal management, it will differ if the patient was on antihypertensive treatment or not on antihypertensive treatment. Okay, if the patient was on antihypertensive treatment, then you have to, once the patient is admitted, you have to do at least 4 times a day while she's admitted. Then once between day 3 and day 5. Then alternate day until normal if the BP was abnormal on the days 3 to 5. And this is the same. If the patient was not on antihypertensive, then in the postpartum period, if you use the medications, your like cutoff will be 150, 100 or higher.
At least 4 times a day we are checking her, okay, as an inpatient. At least once between day 3 and day 5, okay. On alternate days, if BP was, what is it actually? On alternate days until normal, until it becomes normal. If BP was abnormal, we are okay.
Between day 3 and 5, once you measured, if it was abnormal, then you have to measure it every alternate day till it becomes normal.
Okay, ma'am.
Okay. Then if the patient is on antihypertensive, then this is same, at least 4 times a day while admitted. Then every 1 to 2 days for 2 weeks.
Okay.
And then you have to, after that, if the patient has no hypertension after 2 weeks, then you transfer them to community care. And you review them with a GP or a specialist at 2 weeks, and then again after 6 to 8 weeks. Okay.
Medical review after 6 to 8 weeks.
Okay, so this was same even in this thing, gestational hypertension, we were reviewing after 2 weeks.
This is despite taking treatment if the BP is high.
No, for all patients you have to review.
Oh, for all in general.
If the patient was not an antihypertensive.
Okay. This is in general postpartum cases. Okay. Okay.
The patient was on antihypertensive.
Okay.
Then like once you call them for review, what all will you check? You have to check your platelet, answer mini LFT, RFT 48 to 72 hours after birth. Okay. If results are normal, then you need not repeat. If the results are abnormal, repeat as clinically indicated until the results become normal.
Okay. Here platelet should be?
Platelet should be more than 1 lakh, less than 1 lakh we classify.
At least 1 lakh.
Yeah. Then urine reagent strip monitoring. This you do it at 6 to 8 weeks after birth when you call.
Okay.
Results are normal, then you do not repeat. If they're abnormal, that is dipstick more than 1+, then you send them to GP or specialist to assess the kidney function at 3 months. If the kidney function is abnormal, then you refer to the nephrologist, specialist kidney assessment. Okay. Then this was about the management. Then about the recurrence, likelihood of recurrence. So sometimes they ask you this question also. So if the patient had, what is the recurrence of any hypertension? Okay, if the patient has any hypertension, preeclampsia or gestational hypertension, so what is the recurrence of having any type of hypertension? So it is 1 in 5. If any of these is there. Okay, then gestational hypertension, G is a 7-letter, like if you count A, B, C, D, E, F, G, G comes at number 7. Okay. So if there is gestational hypertension, you can remember that risk of developing gestational hypertension in subsequent pregnancy.
Okay.
Okay. So this is how you can remember this. Then again, if the patient has gestational hypertension, risk of preeclampsia is preeclampsia. You can remember like it's a 2-letter word, so it is almost double, 1 in 14. It is
okay.
You can remember, just if there was previously gestational hypertension, then risk of preeclampsia is 1 in 14. Risk of any hypertension is 14%. Okay. If there was any hypertension, risk of preeclampsia is 14% or 1 in 7. So this is generally not asked. What is commonly asked is if there was previously gestational hypertension, risk of gestational hypertension in subsequent 1 in 7. If any hypertension, any type, preeclampsia or anything is there and risk of developing any hypertension, it is 1 in 5. Okay. This is commonly asked. Then if there was this thing, gestational hypertension, risk of preeclampsia is double. Here it is 1 in 7. It is 1 in 2, 1 in 14. Sorry, is half.
Okay.
Preeclampsia, the risk is half, 1 in 14.
Okay.
Then if there was previous preeclampsia, risk of subsequent preeclampsia, it depends, like when the onset was there. If the birth or when the birth, if the birth took early because of the high BP, like 28 to 34 weeks, then the risk is 1 in 6. If the birth was between 34 to 37, risk is 1 in 3. And if the birth was overall it is 1 in 6. If the birth and if you divide it between 28 to 34, it is 1 in 3, and 34 to 37, it is 1 in 4. Okay. Understood?
Yes.
If there was preeclampsia, overall risk of developing preeclampsia in subsequent pregnancy is 1 in 6.
Actually, how to read this tabular column? What are the left sides and what are the above ones?
Yeah, so this is current pregnancy if there is something. So if there is a gestational hypertension in current pregnancy and the patient asks you what is her chance of getting gestational hypertension
next future pregnancy.
So then it is 1 in 7. Preeclampsia in subsequent pregnancy.
So the last column, gestational hypertension. Okay. Actually, it is confusing. The last column is gestational hypertension in ongoing pregnancy.
And you have to predict the risk in subsequent pregnancy.
Subsequent pregnancy. Okay. About for hypertension or preeclampsia or again gestational hypertension. Okay. Similarly for preeclampsia in the subsequent pregnancy. These percentage for future pregnancy.
Yes.
Okay. Okay, ma'am.
So this you have to you can remember it like for gestational hypertension it is
7. Preeclampsia 14.
Preeclampsia 14. So these are the two numbers which are frequently asked. The other thing is not that common. Overall, if any hypertension, if whether it's preeclampsia or gestational hypertension, it is 1 in 5. Okay, any hypertension if they ask you.
1 in 5. Okay. 7, 14, 5.
And then if it is for preeclampsia in current pregnancy, any hypertension is 1 in 5. Subsequent preeclampsia in subsequent pregnancy is 1 in 6. Okay, 5, 6, and 8. Gestational hypertension is 1 in 8.
Preeclampsia in current pregnancy.
Risk in future pregnancy is 1 in 6.
Okay, current is 5.
No. If she already has, what is the risk in the subsequent pregnancy? So this is to predict the risk in subsequent pregnancy.
What is 5 here? 1 in 5 is?
In risk of developing any hypertension, whether it's gestational or preeclampsia, any hypertension is 1 in 5.
Okay. Subsequent pregnancy 1 in 6. Preeclampsia specifically for preeclampsia 1 in 6. And 8 is for gestational hypertension. Okay.
5, 6, 8 you remember, and for gestational hypertension 7.
Yeah.
Okay. So these numbers only you remember, this much is enough.
Okay.
Then medical management, if there is severe hypertension or severe preeclampsia or eclampsia, then how do you manage it? Consider the need for magnesium sulfate if one or more of the following is there. So if there is ongoing or recurring severe headaches, visual scotomata, nausea or vomiting, epigastric pain, oliguria or severe hypertension, progressive duration in laboratory tests like creatinine or transaminases or platelet count. If a woman who has severe hypertension or severe preeclampsia or had an eclamptic fit, then also you give magnesium sulfate. Okay, so these are the indications when you give magnesium sulfate. So there are some symptoms like headache, nausea, vomiting, epigastric discomfort, or if there are worsening features like severe preeclampsia wale features, platelet count falls, there is altered renal function, creatinine is more, transaminases is more, so all that. Okay. And if the patient throws a fit, so you anyways have to give. Okay. So then how do you decide a dose of magnesium sulfate? So you give
prophylactically, ma'am.
Yes, to prevent if she develops a fit, then though you give it for treatment. If she has these severe features, then you give it prophylactically. Okay. So the dose is loading dose. You give 4 gram IV 5 to 10 minutes, 5 to 15 minutes, and then 1 gram per hour infusion you give for 24 hours. So total you have to give it for 24 hours. Okay. 4 gram IV bolus for over 5 to 15 minutes, slow IV you give, and then followed by 1 gram per hour for over 24 hours. Okay. Suppose you have given this and again the patient throws a fit, then what will you do? Then again you repeat a dose. You give 2 to 4 gram is given again over 5 to 15 minutes. Okay. You repeat the dose. Okay. So you repeat the bolus 2 to 4 gram. Okay. Then antihypertensive.
And this occurs after 24 hours of last fit.
Yes.
Okay. There are no chances that it will occur within 24 hours.
If she's on this infusion, 1 gram per hour infusion, if she's on and she throws a fit again, then again you repeat a bolus.
No. I'm asking, is there any chance for the seizures to occur within 24 hours?
Yes. Sometimes patient can throw fit.
Even if it is 6 to 7 hours later, we can start the second dose also.
You can give a bolus again.
You have to give immediately. Okay.
Yes, if there is a fit. Then antihypertensive treatment, then you have to keep the patient in critical care unit and you give them labetalol, oral or intravenous, oral nifedipine or IV hydralazine. And if you're giving hydralazine, so you have to consider using up to 500 ml of crystalloid before or after or at the same time as the first dose of IV hydralazine because it causes hypotension. So you have to give crystalloids with it. Okay. So this was about the management of severe hypertension. Now postpartum management. So for postpartum, the drug of choice is enalapril. Okay. ACE inhibitors. So postpartum you change to enalapril.
So ACE inhibitors contraindicated during pregnancy only.
Yes.
Okay. Postpartum we can give.
Drug of choice.
Okay.
Because it causes more effective control. Then, however, sometimes they give it specifically. They mention that the patient belongs to African ethnicity. So they have done studies and they have found that nifedipine is more effective. Nifedipine or amlodipine is more specifically for these black
African or Caribbean. We don't give them labetalol.
Yeah, labetalol. So, anyways, you don't give anybody in postpartum. You change to enalapril. So that is the first line. If they
in antenatal.
Yeah. So if they just mention that what is a drug of choice for postpartum management of hypertension, then it is enalapril.
Enalapril only. Okay.
Suppose they give you a scenario in which they write that the patient is African. So then it will be your preferred choice. Then it will be nifedipine.
Yeah. Okay. No, during pregnancy, if the patient in pregnancy, if the female is a black, African or Caribbean, whatever, we don't give labetalol, right?
We give labetalol only. We can give nifedipine also.
Okay. Why are we not giving enalapril in postpartum? If the female is
We can give, but they have seen that these drugs are more effective in African Caribbean families.
Okay. So it is about efficacy only. Okay.
But yes, so if they ask you what is your preferred choice, then it will be nifedipine.
Enalapril only. Okay. If specifically, okay. If it's being asked, we can go for nifedipine. Okay.
So if the blood pressure is not controlled with a single medicine, consider a combination of difdipine or amlodipine and enalapril. If this combination is also not tolerated or ineffective, then you add another drug. You add atenolol or lobetalol to the combination treatment, or you swipe one of the medications already being used for lol or labetalol.
Okay.
And use medicines that are taken once daily when possible. Where possible, avoid using diuretics and angiotensin receptor blockers. Okay.
So this was all about the NICE hypertension in pregnancy guideline. Thank you so much.